Let us start. Chronic kidney disease, a silent killer. And this has got the current updates up to 2026 based on the KDIGO, NFK, and KDOQI in clinical practice guidelines. A proactive paradigm shift in the understanding of CKD is presented to you. Now you get some baseline information followed by advanced updated guidelines. So see this iceberg. Less than 0.5% of the volume of the iceberg is seen. Remaining is underneath. Likewise, kidney disease less than 0.5% is visible and 10% of that is under the water. We know now why the Titanic sank, because of the iceberg. So CKD is an iceberg. If you don't unearth it, you will not find it. Whatever visible CKD patients, stage 4, stage 5 CKD with renal failure and transplants are not the ones we want. We want people in the early CKD so that we can prevent transplants and dialysis. So don't wait for pedal edema, ankle edema, facial edema, urine output decreased. Lasix is the only weapon. At best, order blood urea and creatinine. Tromba means much, very much increased in Tamil. Okay, we can't handle it. Immediately pack off to Dr. Renal. That is not what you want. So don't look for a stage 4 cancer or stage 4 kidney failure. We as physicians have the onus to prevent the disease and see that we get the fellows early. So Kidney Disease Outcomes Quality Initiative, KDOQI. KDOQI is Kidney Disease Outcomes Quality Initiative and International Guideline. NKF, National Kidney Foundation. NKDP, National Kidney Diseases Education Program. All these guidelines are there in your presentation today. CKD is a major global pandemic like diabetes. Diabetes and hypertension make CKD burden very high. You know that 100 cases are CKD are there, 80 of them are either diabetes or hypertension. If you take care of hypertension and diabetes properly, you don't have the reason to have a renal specialist. The nephrologist will be out of job if you properly treat diabetes and hypertension. CKD predicts the CVD. The major predictor of CVD is CKD. Testing and therapy are inadequately used. Knowledge about CKD is at best sketchy. As I told you, ankle edema, blood urea raised, Lasix give back to renal. That is only that much only. Beyond that, you don't know. Testing and early therapy are economical. Most of the progression is preventable. CKD is preventable. Do we care about CKD? Doctors do not realize that CKD is hidden in their patients of diabetes and hypertension in elderly people. Most doctors screen less than 10% of their clinic patients for CKD in the early stages. Patients are referred very late to the nephrologist, especially after the CKD is irreversible. Only less than 1/4 of the people with identified CKD get an ACE inhibitor. All of them are true, not only in India, over the globe this is the case. Okay. Now, CKD and increased death, you see more than 60, 45 to 59, 30 to 44, 15 to 29, less than 15. This is not age, this is estimated GFR. If the estimated GFR is more than 16, the death rate is low. If the estimated GFR is less than 15, you can see around 14 is the death. CKD at a glance, a global pandemic, 1 and 2 are asymptomatic, stage 1 and 2 are asymptomatic, third after CVD and cancer. This is the third largest mortality cause. CVD, cardiovascular disease, cancer, and then the CKD. 1 in 10 Indians have CKD. 10 million people have CKD. The term CRF, chronic renal failure, is no longer used. You have to call it as chronic kidney disease. Dialysis increases death rate by 100 times. Small increase in the creatinine large increase in the cardiovascular events. Now you see here, stage 4, less than 15, stage EGFR, that is called end-stage renal disease, and stage 5, stage 4, 15 to 29, stage 3, 30 to 59, stage 2, 60 to 89, stage 1, more than 60, but albuminuria is present. So as you see here, the number of people in millions, people in stage 1, stage 2, stage 3 are so many, and they are the ones who are going into stage 4 and stage 5. So you need to cater to the first 3 stages as physician, 3 to 5. What are the warning signs or red flag signs? Unintentional weight loss. Some person is losing weight. Think of CKD. Nausea, vomiting, general ill feeling, fatigue, headache, frequent hiccups, generalized pruritus, increased or decreased urine output, either polyuria or oliguria, need to urinate at night, nocturia, easy bruising and bleeding. If any of these things you see, these are the red flag signs or warning signs of CKD. Next one. Blood in the vomit or in the stools, decreased alertness and muscle cramps, seizures, agitation, hypertension, peripheral sensory neuropathy, breath fever, water in the breath, loss of appetite, uremic frost on the skin, uremic pericarditis, and CHF late signs. Now, who are at risk for CKD? I told you diabetes and hypertension contribute to 80% of the problem. The elderly people, family history of kidney disease, systemic infections, recurrent UTI, urinary stone disease, loss of renal mass, neoplasia in any part of the body, and finally, nephrotoxic drugs also are the culprits. The etiology of CKD, most common cause of end-stage renal disease, 13 times more common in diabetes. Okay, over 30% of ESRD are primarily due to diabetes. CKD alone associated with hypertension, 3% of the ESRD, end-stage renal disease, is CKD hypertension. Glomerulonephritis, 10%. PKD, polycystic kidney disease, 5%. Rapidly progressive glomerulonephritis, vasculitis, 2%. Drug-induced tubulointestinal disease is also rare. Renovascular disease like renal artery stenosis, atherosclerotic fibromuscular are rarer causes. All of them put together 20%. Diabetes plus hypertension, 80% are the cause. Now you see here, glomerulonephritis, 13% other causes, 10% diabetes, 50% hypertension, 57. Means what? 80% of the problem is in your hand in properly treating hypertension and diabetes. Primary diagnosis for patients who start on dialysis. This is from international studies. Now, what are the causes of CKD? You see, diabetes ranks 1, hypertension, glomerulonephritis, secondary glomerulonephritis, vasculitis, interstitial nephritis, pyelonephritis, cystic or hereditary congenital diseases, neoplasia, miscellaneous. Again, this slide emphasizes 44 plus 26, 80% of the patients of CKD are due to diabetes. CKD predicts CVD. If more than 60 EGFR, 2.11. Less than 15 EGFR, cardiovascular events are 36.6%. That is, it is a forewarner and it is like a jatakam for CVD. It is like a horoscope. If somebody has got CKD, you are sure he will end up in CVD very soon. What is the definition of CKD? Either glomerular filtration rate less than 60 ml per minute for 1.73 meter square for more than 3 months. That means patient will have less than 60 millimeters of EGFR. How to calculate the EGFR, estimated glomerular filtration rate? I will show you later. Kidney damage for more than 3 months as manifested by persistent microalbuminuria, macroproteinuria, biochemical abnormalities in the RFT, persistent urological hematuria, structural renal abnormalities in the ultrasound, biopsy in glomerulonephritis, rarely needed to diagnose CKD. Any one of the above evidences. One simple thing is measure the GFR. If the GFR is less than 60, straight away it is CKD2. Okay, or persistent microalbuminuria, macroproteinuria, biochemical RFT abnormalities, non-neurological hematuria, and then abnormalities in the USG, biopsy proven glomerulonephritis. Rarely we need a biopsy to diagnose. Now, what are my stages? You must know the clinical stages. Kidney damage with normal or increased GFR. That means GFR is normal, but there is evidence of structural parenchymal kidney damage. Second one, kidney damage with mild decrease in the GFR 60 to 89. That is stage 2. Stage 3 is kidney damage with moderate decrease in the GFR, that is between 30 and 60. Severe reduction in GFR 15 to 29. Less than 15 eGFR, also called the end stage renal disease, requires dialysis, and that is stage 5. You must classify the patient. Don't say CKD. You must stage the disease. Stage 1 CKD, stage 2, stage 3, 4 and 5. 4 and 5 are with the nephrologist. 3 is with you as well as with nephrologist. 1 and 2 you have to manage because the nephrologist is not required for early stages. Now you see 20 million people are at risk. 11.2 million are in stage 1 and stage 2, 7 million are in stage 3, 400,000 are in stage 4, 300,000 are in stage 5. That means the number in the stage 4 and stage 5 are lesser, and they are produced from the bottom. It is like a pyramid. If you take care of stage 1 and stage 2 and stage 3, you can prevent the onset of stage 4 and stage 5. Now you see, this is the KDOQI CKD staging. That is GFR more than 90. Other markers of kidney disease, proteinuria, hematuria, anatomic conditions. That is called stage 1. GFR is more than 60, but he has got other markers of kidney disease. It is called stage 2. Between 30 and 60, this is called stage 3, complications possible. Between 15 and 30, complications are evident. Less than 15, RRT, renal replacement therapy, either in the form of dialysis or in the form of a transplant, will be required. So you should remember the various stages of kidney disease. Now you see the paradigm shift in the evaluation of eGFR estimation. So creatinine alone, you see very inaccurate, very low, variable precision. What you order? RFT creatinine. What does it tell? It did not tell anything. Creatinine is a very poor marker of kidney disease. Can I do cystatin C? Yeah, much better. 95% accuracy. Sensitivity is very good. Diagnostic accuracy. The better thing would be CKD EPA 2021 eGFR creatinine cystatin. That you have to do. eGFR as measured by creatinine titrated against the cystatin C. Highest precision, the new gold standard for the diagnosis of CKD. This is from 2025 recommendations. Combined equation yields the truest estimate of around 90%. Sensitivity and specificity are 90%. Now, you do creatinine, nobody is objecting, but don't stop short at that. Creatinine, cystatin C, and CKD EPA 2021 eGFR creatinine cystatin ratio you have to do. Earlier, while doing the eGFR estimation, we used to add race as one of the factors. Now, in the latest guidelines, they have removed that black race from the equation. Removing race from the equation addresses structural health inequalities, preventing false perceptions of better kidney function in black patients. Previously, we used to say black people are protected from kidney disease, and you factor the race as one of the things. Now, they also seem to enjoy no protection, and we remove black from the equation, accelerating the equitable access to nephrology to all patients, blacks, Negroid race, Caucasians, Hispanics, Asian Indians, everybody, and also for transplantation. Now, what is the message? You have to classify the kidney disease. How? Less than 15, worst, stage 5, less than 15 to 30, stage 4, both require the attention of nephrologist. between 30 and 60, stage 3, physician's role, 60 to 90, stage 2 with associated structural renal disease, more than 90 but proteinuria, hematuria, parenchymal damage is evident, stage 1. So this staging is important, and for diagnosis, don't depend on creatinine alone. You have to do cystatin C alone also is not adequate. You have to use creatinine and cystatin C as the biomarker and calculate the eGFR based on creatinine clearance versus cystatin. That is the gold standard today to diagnose CKD. Now, you see here, less than 10 eGFR, 20 eGFR, 30 eGFR, 45 eGFR, 60 eGFR, more than that, this was previous classification. What we are doing, we are waiting for failure from 60 fellow to go to 45, 45 fellow to go to 30, and finally dive in the renal transplant unit. That's not what we want. And most of the CKD patients, they don't die with the nephrologist. They die with the cardiologist because CKD yields CVD and then they succumb to cardiovascular disease. The commonest cause of death in CKD is CVD. The older paradigm of 60, 45, 30 is no more used. Present day risk-based care, intercepting the trajectory. KF, kidney factor risk score, more than 33 to 5%, 5-year survival. Risk score more than 10% at 2 years. Risk score more than 40, 2 years. So, if somebody has got a risk score of 3 to 5% and survival of 5 years, he is better placed compared to somebody with a risk score of more than 40% and 2 years survival. Intercepting the trajectory anywhere, there is no stepping here. Every point is a step. Action driven by calculated kidney risk and of risk failure regardless of the current stage. You have to calculate the KF risk and act according to the KF risk. This is of course based on the cystatin eGFR only, but the risk ratio has to be calculated. Now you see, the proteinuria, stage 1 disease, more than 90 eGFR, BP normal, microalbuminuria present, urine normal, no edema, no anemia, calcium into phosphorus ratio is less than 50. If you multiply calcium into phosphorus, what is the normal calcium value? 9. What is normal phosphorus value? 4. 9 into 4, 36. If it is more than 50, it is kidney failure. So in this fellow, first stage, Ca into P is normal. And also if you do the parathyroid hormone, it is normal. So the first stage is eGFR is raised, BP normal, ACR positive, MAU positive, urine normal, no edema, no anemia, CAP product is normal, no parathyroid shift. Stage 2, 60 plus eGFR, less than 90, BP already increasing, microalbuminuria, urine output is increasing, no edema, anemia may be there, may not be there, calcium phosphate product is normal, and there is yet no increase in the parathyroid hormone. There is no osteoporosis or osteopathy or osteodystrophy. Stage 3, 30 plus to 60, 30 to 60, BP increased, frank albuminuria, macroalbuminuria, urine output increased, no edema, anemia already started, CAP ratio normal, parathyroid started increasing, hyperparathyroidism and bone thinning, von Reckling-Hausen's disease, the cystic changes in the bone, this is started. Stage 4, 15 to 30 is the eGFR, BP increased, macroproteinuria, urine started decreasing in volume, edema started appearing, anemia is now profound, calcium phosphate ratio has increased, now parathyroid is very elevated already. Stage 5, less than 15 eGFR, BP doubly increased, albuminuria, macroalbuminuria, oliguria is there, edema is persistent, anemia is very severe, CAP ratio is more than 50, and parathyroid excess is already seen. If you remember this, you know what to investigate. Every patient you should look for diabetes, of course, you have to exclude blood pressure, albumin creatinine ratio, macroproteinuria, microproteinuria, urine volume, look for edema, look for hemoglobin, calcium and phosphorus, the product, and also look for the parathyroid hormone. This is a very summary slide to tell you how to go about. Now, you see, this is the nephrologist and you. Grade 1, grade 2 are yours at increased risk, and grade 3 is both. Grade 4 and grade 5 are end-stage renal disease. The red line is the primary care provider. The yellow line is the nephrologist. Nephrologist takes over midway at around stage 3 to 4 and 5, and that is around 45 eGFR. And anything more than that, you have to manage. Because if there are no enough nephrologists or dialysis units in the country, this country cannot afford to have dialysis units and transplant centers everywhere. Everybody cannot afford to have Manipal type of care. What you have to do, you should avoid people getting into the need for renal replacement therapy. That means you have to act now and see that you prevent the progression. You prevent the progression. Now, you see here, risk stratification, kidney failure risk equation. This is what I am mentioning. KFRE, kidney failure risk equation. How to calculate that? Just open your medical app then and look for KFRE. It will ask variables. You fill the variables, the risk will be given. Okay, any MedCalc or Medicalc or any other medical calculators are having KFRE risk estimate. It will ask the age, gender, and then the diabetes plus or minus, BP value, creatinine, eGFR, cystatin. All these we have to factor in. Then you get a risk, 3 to 5% risk, 5-year risk, threshold for nephropathy, nephrology referral. This is the fellow whom we want to protect from disease. More than 10%, multidisciplinary care, intensive education, and transition to care coordination. More than 40, final KRT, kidney replacement preparation, and then the vascular access surgery. You have to put a shunt there for the dialysis and active transplant listing. You have to put him on the transplant list, and he will wait for his turn for the transplant. KTKs shift focus from treating the current GFR number to treating the 2 to 5-year risk. Earlier we were focusing on the eGFR and staging. That has gone now. Now use the eGFR number also, use the creatinine also, and then predict the risk ratio. This is called KFRE, and depending on that, is it between 2 to 5%, more than 10%, more than 40%, when to take action. This is listed in this paradigm shift. Who is to be tested? Regular testing of all people for CKD is a must. Who are the candidates? All diabetics, whether type 1 or type 2 of any age. All hypertension patients, systolic or diastolic hypertension. All patients having a relative with a kidney disease. All patients of cardiovascular disease, all patients who are obese, metabolic syndrome, and smokers. If I give you these 5 lines, try and go into the OPD and exclude one fellow out of this. There won't be anybody. Everybody will have any one of these problems. So you have to test everyone almost. Don't sleep, all of you. Investigating CKD. Risk factors, CVD, diabetes mellitus, hypertension, metabolic syndrome, age, smoking, family history of CKD, BMI, NSAID. Serum creatinine, eGFR, cystatin, proteinuria, microalbuminuria, urine creatinine, albumin creatinine ratio. Urine for hematuria, CAS, crystal, sodium, specific gravity, electrolytes, calcium, phosphorus, IPTH, that is parathormone, and FENA, fractional excretion of sodium. USG, renal angiography, only in the selected cases. Now, 2 important tests for CKD. Test serum creatinine, note age and gender, estimate the eGFR using the MDRD equation, standard dipstick for protein. If negative, spot albumin creatinine ratio. How many of you are ordering albumin creatinine ratio in the urine? Start doing it. 24-hour urine collection is not needed. Diabetic should be tested at least every year. Others at risk should be tested every 2 years. What is eGFR? The watchword, estimated GFR. How do I know? 65 in a 65-year-old lady with 50 kilos, diabetes and hypertension, even 87% of the doctors said creatinine of more than 5% is normal. I have given a lady, let us say 65 years, 50 kilos, diabetes, hypertension, gave you the creatinine report, no problem, 1.5. Very, very wrong. Why? If serum creatinine is 1.5, eGFR is 37 if we calculate. What is 37? Between 30 and 60 is the stage 3 disease. You understand? If the serum creatinine is 1 milligram in the same lady, eGFR is still 59 only. That means she still comes under stage 3 disease. So, majority of the time, you brush away creatinine around 1.2, 1.3, 1.4 as normal. Don't do that. You estimate the eGFR. That is the mess. How do I do? There are two methods. One is called the MDRD, the other is called the CG equation. Inulin, I-125 clearance tests are used. Creatinine clearance also can be used. So what is the MDRD equation? Looks very complex. Don't worry. What you have to do is, you have to tell the creatinine, age, gender, and the African American. Now in the new calculation, the African American also is removed. And that calculation gives you an estimated eGFR. Don't be afraid. We have the help in the form of calculator. Okay. So another important test is albumin. Microalbuminuria is very important. Estimating eGFR, doing a creatinine cystatin C, and also doing a urine albumin. The 24-hour urine days have gone. There is no need to carry a big bottle around for one day and then collect urine. That is not required. Spot urines are adequate. Spot urine only. What is microalbuminuria, albumin creatinine ratio? ACR, urine microalbuminuria in milligrams per liter, urine creatinine in milligrams per deciliter multiplied by 100. If microalbuminuria is 60, urine creatinine is 120, the calculation will be 50. Anything more than 20 is abnormal. Okay. Now, how to say? No albuminuria, 30 milligrams per gram we used to take. Now today the revision has come. 20 milligrams itself is the cutoff. Microalbuminuria 20 to 300. Macroalbuminuria more than 300. Nephrotic proteinuria more than 3000 or 3 grams. This is how you classify. No microalbuminuria less than 20 milligrams per gram. ACR is less than 20. Microalbuminuria 20 to 300. Macroalbuminuria more than 300. Nephrotic proteinuria more than 3000. This is how you have to interpret the result. So, importance of albuminuria in CKD. It is a marker of the CKD. Okay. It is a clue to diagnose CKD. It is a prognostic index. It is modified by treatment. It is a surrogate goal. That means if microalbuminuria is improving, your treatment is working. Treatment of CKD, renal diet with adequate protein, salt and water. Consult nephrologist early from stage 3 itself. Team with the nephrologist for care if eGFR is less than 30. Monitor hemoglobin and serum calcium and phosphorus. Treat cardiovascular risk factors, especially smoking and hypercholesterolemia. Now, metabolic effects of CKD. This is a short notes. Usually, please write the metabolic effects of chronic kidney disease. It starts in 3, 4, and 5 stages: hyperkalemia, metabolic acidosis, fluid loss or fluid overload, hyponatremia or hypernatremia, normocytic normochromic anemia, increased phosphate and decreased calcium, decreased vitamin D formation, secondary hyperparathyroidism, renal osteodystrophy. These are the metabolic effects of CKD. Each one you can write what is normal calcium, what is hypercalcemia, how it manifests, like that metabolic acidosis, fluid loss, fluid overload, hypo or hypernatremia, normocytic normochromic anemia, increased phosphate and calcium. We have diagnosed several fellows who came with anemia, normocytic normochromic anemia, diabetes and adult, when aged around 50, 60, look for CKD, CKD is there. So, vitamin D levels also are important. Secondary parathyroid. The ABCD of handling CKD. A1C less than 6.5, ACE inhibitor or AR. B, blood pressure 120/70. C, cholesterol less than 100. D, drugs to avoid nephrotoxic drugs to be avoided. Moderate protein, sodium, potassium, phosphorus, fluids, and calcium. This is about the ABCD of CKD management goals. Blood pressure today 120/70. When we were teaching these slides earlier, it 120/75. Now today the blood pressure goal is less than 120/70. Hypertension is both a cause and also a consequence of CKD. CKD can produce hypertension. Hypertension itself can produce CKD. Glycemic control less than 6.5. Hemoglobin level must be maintained more than 11 grams. Calcium phosphorus product should be less than 50, as I already told you. GFR normal values 120 to 150 normal, calcium 9 to 10.5, phosphate 3 to 4.5, calcium and phosphate less than 50. IPTH 150 to 300 picograms. If there is hyperparathyroidism, it indicates secondary hyperparathyroidism due to renal disease. You see here, no treatment. After a time in 7 years, eGFR falls to 10 in 7 years. If you start treatment, current treatment, it takes 9 years for the same eGFR. If you have it very early treatment, it takes 11 years to reduce the GFR. That means if you start early, you can prevent the end-stage renal disease. Blood pressure treatment, maintain 120/70, use ACE inhibitor and ARB very early. More than one drug is usually required. Diet should be part of the regimen. Achieve best possible glycemic control in diabetes. Renal injury triad, hypertension, proteinuria, angiotensin. These three together produce chronic renal disease and end-stage renal disease. Now you see ACE inhibitor, losartan, and you see if you use the blue line, ACE inhibitors are the best, losartan the second best. Combination don't use because combination people did worse than individual drugs. Either ARB or ACE inhibitor, both are same today. Earlier ARBs are different. Today we have telmisartan and then olmesartan. These are as good as any ACE inhibitor. Now, evaluation of diabetic nephropathy. Tightly controlled people will survive for the eGFR reduction is not there. Less controlled people, the eGFR fairly good. Poorly controlled, very quick fall in the eGFR. So same with where they started, depending on the diabetes control, the progression of nephropathy will be there. Diabetes and proteinuria. You see microproteinuria in the early stages, normal glucose tolerance, impaired glucose tolerance, and then 0 to 4 years, 5 to 9 years of diabetes, microalbuminuria. After that, slowly it is replaced by the macroproteinuria. Now you see the complications. Normal screening for CKD risk factors. Increased risk reduction, screening for CKD. Damage, diagnosis and treatment, treat the comorbidity conditions and decrease the progression. Decrease in the eGFR, estimate the progression, particularly the kidney failure risk ratio you have to calculate and complications you have to treat, prepare for replacement. Replacement and dialysis once it is stage 4 and stage 5. Finally, CKD death. This is the progression or natural history of the disease. Now, stage-wise management. What do I do? Stage 0, test for CKD, manage the risk factors. Stage 1, manage the comorbidity, particularly diabetes, hypertension, and treat for CVD and risk factors. Stage 2, slow the rate of loss of kidney function, prescribe ACE inhibitor or ARB. Stage 3, prevent anemia, bone effect, and see that the calcium phosphate product is less than 50. In stage 4, prepare for the renal replacement therapy, kidney replacement therapy and refer for nephrology. RRT, peritoneal dialysis, hemodialysis, or if the renal transplant, donor transplant, or cadaver transplant. Now, microalbuminuria in type 2 diabetes heralds rapid decline in eGFR. If a patient has got microalbuminuria, that is the microalbuminuria is that particular first line. Then suppose the patient becomes macroalbuminuric, how fast he deteriorates. You see, very fast. In 3.5 years, he goes to eGFR of less than 50. Whereas microalbuminuria stage, it will after 4 years also, he will continue to be having good eGFR. That means preventing macroproteinuria and treating microproteinuria itself with ACE inhibitor and ARB is very beneficial for all the patients. Now, you see, diabetics with MAU are more likely to die of CV than with ESRD. I told you now, these people don't die in the kidney unit, they die in the cardiac unit. Why? No albuminuria, 1.4%. And then there is microalbuminuria, 3%. So number of people, 2%, 2.8%. Macroalbuminuria, CV death, 4.6%. Then you have elevated serum creatinine, 19% of the deaths of cardiovascular deaths. That means 20 fellows of every kidney failure fellow will die of cardiovascular death. So this is a United Kingdom prospective diabetes study, the basic data published already there. Diabetic nephropathy, lower blood pressure to 120/70, reduce proteinuria, not combination, individually ACR, ARB, multiple risk factor intervention, glycemia, dyslipidemia, physical activity, early aspirin for the protection, and smoking cessation. Now, anemia is an important CV risk factor for CKD. Don't ignore anemia in a fellow with CKD or CVD. Chronic kidney disease, anemia, cardiovascular disease are perpetuating one another. Anemia and CKD is due to what? Low erythropoietin due to renal failure, nutritional, iron B12 and folate deficiency, inflammation may be the cause, infection and calcium. Also, blood loss, hematuria, serum erythropoietin levels are not indicated. Do not measure serum erythropoietin. It is a useless test. It will not reflect the need. If you find anemia in CKD, you administer erythropoietin. Available directly as injection. Reticulocyte count, red blood cell count, indices of MCV, RDW, and then the iron parameters, TIBC and serum ferritin, vitamins, folate and B12 levels, stool for occult blood, not serum erythropoietin. Okay, RDW is red cell distribution width. It should be normally 14 or less. If the width is more than 14, that means some are microcyte, some are macrocyte, some are normocytes, then the RDW will be very wide. You can see from your reports what is the RDW, red cell distribution width. Okay, principles of anemia treatment, epogen is available, erythropoietin, epotin alpha, darbepoetin alpha, these are available, Arnasep, various brands are available. When do I give? Target 11 to 12 grams is my hemoglobin target. PCV must be 33 to 36. Iron supplementation must be given along with erythropoietin. TSAT, that is saturated total saturation of iron, more than 20%, serum ferritin levels, more than 100 nanograms per ml. Okay, now bone health, feedback loop and serum hyperparathyroid, secondary hyperparathyroidism. SHPT is secondary hyperparathyroidism. Decreased vitamin D receptors and calcium sensing receptors, and in what will happen? The calcium is withdrawn from the bone. And then at the kidney level, because of renal failure, phosphate will be retained and the 125 dihydroxylation of calcitrol, that is active form of vitamin D, is not there. So because vitamin D is not active and phosphate has increased, in order to match the phosphate, calcium is drawn out. Because vitamin is not there, calcium is not deposited, bone thinning occurs, hyperparathyroidism occurs. Now, calcium and phosphorus balance. Aim to normalize calcium and phosphorus PTH levels. Method: oral calcium, vitamin D analogs, phosphate binders like sevelamer, Renagel and calcium mimetics are also available. Senacalcet and Sensipar. These are a spray, they are available. This is the calcitonin is available. Phosphate control. Dietary restriction of phosphate binders decrease the absorption, calcium carbonate, bone stat, simple phosphate binder, calcium acetate, phoslo, sevelamer, Renagel, aluminum hydroxide, aluminum carbonate, phosphorenol, lanthanum carbonate, these are all the phosphate binders. If you find the CKD is worse and the phosphate is higher, you have to use one of these phosphate binders or remove the phosphate by dialysis, which is not a good way of doing it. How to restrict the phosphate? What are the phosphate containing foods? Milk, some of the nuts, this cheese, eggs, yogurt, these are very rich in phosphate. Special treatment in CKD, calcium acetate, phoslo to prevent the absorption of phosphate, calcium, not carbonate, sandocal, bonestat, oystercal, sipcal, any of these calcium carbonates. And then say calcitrol, vitamin D should be supplemented. Doxorcalciferol, vitamin D analog can be given 3 times per week. So vitamin D supplementation, calcium supplementation, and phosphate binding are the treatments. Sevelamer or calcimimetics, senacalcet or eplerenone, which is the selective mineralocorticoid antagonist, lanthanum carbonate, which is the phosphorenol. All these are good drugs to prevent phosphate absorption, phosphate binders, and reduce the hyperphosphatemia. Now you have got how much fluid I should give. This is a very, very important question. If the patient is already wet, don't give much fluids. If the patient is having polyuria, you give enough fluid. Depending on the urine output you have. High energy foods, yes, you can give high energy foods, but spare the phosphate. And then protein, how much I should give? 0.6 grams per kilogram. If a person is 70 kilograms, he must receive at least 30 to 40 grams of protein. Protein should not be totally stopped because it produces wasting and cachexia. Simple salt rules. Do not add salt to your food at the table. Do not use flavored salt like garlic salt or sea salt. Use only a small amount of salt in cooking. Do not use salt substitutes like Lona. There is one product called Lona that is low sodium. That also don't use. Use herbs and spices as flavoring agents in place of salt. Pickles, tinned foods, tinned juices, chips, savories, papads, salted fish, seafoods are very rich in sodium. Recommended salt intake is less than 2 grams per day. Okay, sodium 1.5 to 2 grams, and you see what are the foods which are contributing to sodium. Potassium liberal, you can give potassium containing foods, particularly fruits, tomatoes, and then potassium supplements. Low potassium diet, high potassium diet. Many people ask, what is high potassium diet? What is low potassium? Fruits, vegetables, fruit juices, coffee, all. Dry fruits, banana, mango, grapes, pineapple, grapefruit. Tomato, beetroot, spinach, sweet corn, plantains. Chocolate, toffees, deep fat fried sweets. Snacks, all nuts and potato chips, crisps, baked or roasted potatoes. You have to choose which one you use depending on his other metabolic conditions. Okay. Now, important guidelines, interventions to slow progression of CKD, glycemic control, BP control with ACI, ARB, protein restriction, lipid lowering, weight reduction, anemia treatment, smoking. To be avoided to prevent acute reduction in EGFR, volume depletion, radiographic contrast. Be very careful. If you want to do some contrast studies, don't have, they always do a serum creatinine before that. But they ignore 1.5, they call normal and give. It's not correct. So you have to do EGFR. Antibiotics, NSAIDs are very toxic antibiotics are there, particularly the aminoglycosides, netilmycin, streptomycin, kanamycin, all these mycin, all your papa. Mycin is papa. all papas are all antibiotics of nephrotoxic. NSAIDs, particularly the ibuprofen and diclofenac group of drugs, cyclosporin, tacrolimus, ACE inhibitors are contraindicated if serum creatinine is more than 3.5. Obstructive uropathy also, you have to be very careful, you deal it. Preparation for RRT, renal replacement therapy. Choice of RRT, timely access surgery, dialysis initiation. If the GFR less than 25, renal transplant is the first choice. Per cup living donor. If no donor is available, list the patient for cadaver transplant. Place IV fistula if HD, hemodialysis is preferred. CAPD, continuous ambulatory peritoneal dialysis. CCPD, continuous cyclical peritoneal dialysis. PD catheter placement by LAP, that is the laparoscopy. URR, urea reduction ratio 65%. KT by V ratio should be less than 1.2. Tests are done monthly. How do I do the peritoneal dialysis? You keep the tube there in the peritoneum there. There is a bag containing dialysis solution. Internal organs are spared. Peritoneal catheter is introduced and the fluid is left in place for quite an amount of time. And finally, the fluid is drained. That's how the peritoneal dialysis works. AV fistula, access for the hemodialysis. You prepare the fistula. Hemodialysis centers are now like cutting salons in Western countries. If you want haircut, you go to a salon and sit. Like for hemodialysis, 3 days in a week, they go there, sit there for 2-3 hours. Hemodialysis is done. They read their book and come. This is how things are changing. But we don't have ability for all those things. We don't have the richness to do that. Absolute indications for hemodialysis: EGFR less than 15, creatinine is more than 8, 1 more than 100, potassium more than 7, refractory CHF, diuretic failure, accelerated hypertension, uremic pericarditis, encephalopathy, uremic bleed, and vomiting. Acute indications: poisoning, dilagible poison, overdose of poison, acute renal failure more than 48 hours, EGFR less than 30, metabolic acidosis, hyperkalemia, and hyperphosphatemia. These are the indications for HD, hemodialysis. What are nephrotoxic drugs? A short notes. Write short notes on nephrotoxic drugs. Which drug is not nephrotoxic? This is my question. Every drug almost is nephrotoxic in some dose or other. Aminoglycosides, Indianavir, amphotericin, penicillins, beta-lactams, tetracyclines, fluoroquinolones, sulfurs, ketoconazole are notorious. NSAIDs, COX-2 inhibitors, indomethacin, nimesulide, cancer drugs, methotrexate, cisplatin, acyclovir, pentamidine. Heavy metals, mercury, plumbum, lead, arum, and then beryllium, and then the lithium. IV contrast dyes, ACI and ARPs. If serum creatinine is more than 3.5, these drugs also are nephrotoxic. Mechanism of nephrotoxicity: direct injury to the PCT and the glomeruli, allergic interstitial nephritis, crystallization in the renal tubules, fluid overload on the kidney, renal papillary necrosis, particularly NSAIDs, metabolites may be toxic, side effects may increase in renal failure. How do I avoid nephrotoxicity? Adequate fluid intake is essential, dehydration to be avoided, reduce the dose or avoid the drug in case of nephrotoxicity. Now, modern management. SGL2 inhibitors have come for every disease, including cardiac failure, including renal failure, including metabolic syndrome, of course, diabetes. The foundation is SGL2 inhibitors. Baseline disease modification for CKD with or without diabetes. Mechanism: hemodynamic stabilization and risk reduction. GLP-1 receptor antagonist, the fourth pillar that is added. Primary kidney and CV protection in type 2 diabetes. Metabolic and weight management, albuminuria reduction. NSMRNA, phenyrenones are the newer drugs preventing progression in diabetic nephropathy, anti-inflammatory, anti-fibrotic, mineralocorticoid, receptor blockade. These are all from the latest guidelines. SGLT2 inhibitors, GLP-1 receptor antagonists, NSMRAs, phenyrenones are the newer drugs. Now, beyond glycemic control. The SGLT inhibitors are beyond glycemic control. They are very useful in credence, core, DAPA-CKD, EMPA kidney. All trials have shown benefit with SGLT2 inhibitors. 37% relative risk reduction in case of CKD, 23% risk reduction in case of acute kidney injury. See the value of these drugs now. This is grade 1 recommendation. This is class 1 mandate. Every person treat all adults with eGFR more than 20 and urine albumin creatinine ratio of more than 200 or heart failure, irrespective of diabetes. You must use SGLT inhibitors. Okay, there is a 24% risk reduction breakthrough semaglutide, that is the GLP-1 receptor antagonist 1 milligram, stopped early for profound efficacy. The control arm is stopped and everybody started getting semaglutide because semaglutide was so useful. Safety endpoints and then the number required to treat, everything showed a 25% risk reduction with GLP-1 antagonists. Now, the trade-off, this is the NSMRA's finerenone group of drugs and potassium management. Benefits, Fideligo trial, Figaro trials, 18% risk reduction in primary kidney outcomes, 13% risk reduction in primary kidney outcomes with these in both the trials. The trade-off, 2.2 times relative risk of hyperkalemia. So you have to be very careful of potassium management when you use these drugs, particularly finerenone. Do not prematurely abandon fundamental therapies. Use potassium binders as a bridge to mitigate hyperkalemia, allowing patients to maintain life-saving RA inhibition and NSMRAs. So what are the new treatments? One is the SGLT2 inhibitors, second one is the GLP-1 receptor antagonist, and third one is the NSMRNA antagonist. Like these are the finerenones. These are the three newer drugs that are added. Systemic lifestyle management, modern dashboard. Less than 120 BP, if the aggressively treat when serum bicarbonate falls below, at least keep 22 bicarbonate. Blood pressure should be 120 or less. And then moving away from restrictive diets, prioritizing the plant-based proteins, Mediterranean patterns to manage load and control potassium safely. These are the modern dashboard of systemic lifestyle management. And finally, the bone. The bone you have to be very careful, shifting framework toward preventing CKD-associated osteoporosis, CKD-associated CVD, emphasizing the clinical biomarkers and imaging over invasive bone biopsies in modern era. How many physicians are evaluating bone mineral density in a patient of CKD? Nobody does. Somebody has fracture also, orthopedicians are not doing. So if you have to see what is the bone health by doing DEXA scan, proactive target hemoglobin to 10 to 12 grams or 100 to 120 grams per liter, 10 to 12 grams per cent. Proactive iron treatment, consider high dose, low frequency IV iron, serum ferritin should not exceed 800 and then 700 or 700. Non-HD, non-hemodialysis patient or 700 in the hemodialysis patient. So proactively bone management and anemia management are essential. Now, the adult PKD, diagnostic risk, new ultrasonic criteria for diagnosis of at-risk families. Every patient of CKD, you must image for polycystic kidney disease and then obtain mixed score, that is Mayo Imaging Classification Score, to accurately predict the trajectory and the risk of kidney failure in a patient with polycystic kidney. 12-heptane must be continued, aggressive disease modification, absolute necessity, ongoing total kidney volume, TKV has to be maintained. So this is another area where you can show some AKPD guidelines also can be brought in here to treat the CKD. Now, adult and pediatric. Adult paradigm, standard GFR biopsy may be required. Pediatric, low GFR defined differently, but for their age and muscle mass, prioritization of genetic testing is important. Hemodynamics, systolic blood pressure in adult must be less than 120. Aggressive BP control aiming to the 50th percentile and 24-hour ABPM also should be done. Nutrition mandate, do not restrict the protein. Target protein and energy at upper end of the normal to prevent severe neurodevelopmental and physical growth impairment, particularly in the pediatrics. Now you have transitions of care, pediatric to adult handover, from 11 to 14, transition preparation, late adolescence, formal structured handing over, both pediatric and adult multidisciplinary teams to ensure zero gaps in the care. And now finally, you have the medication stewardship, implementing sick day rules. When the patient is sick, particularly in case of AKI on CKD, acute kidney injury on CKD triggered by volume depletion, while on hemodynamically active medication, particularly prolonged fasting, surgery, critical medical illness, and then the gastroenteritis, vomiting, nephrotoxic drugs or active drugs, temporarily withhold SGL2 inhibitors, RAC, diuretics, and NSAIDs. Don't be afraid to stop these drugs if the patient is volume depleted. Once it becomes normal, you can restart these drugs. You must also know the stopping rules for these drugs. Now, finally, patient care is a shared decision-making, nephrologist, clinical pharmacist, primary care, endocrinology, renal dietitian, all together. The transformative guidelines and breakthrough pharmacologics only succeed with a synchronized multidisciplinary care ecosystem. This is a proactive paradigm which we have to follow. It is not one team, it is not one discipline, it is a team effort. And this is not, that is not normal kidney you see on the left side, what mother has given to you. And stage renal disease, scarred and contracted kidneys you see on the other side, it is less than 5 centimeters. Normal kidney size is about, normal kidney size is something around 9 to 10 centimeters. Here the contracted kidney is less than 5 centimeters. You don't allow the patients to develop end-stage renal disease like this. Okay, so the idea is you have to prevent end-stage renal disease in every patient. Okay. Now you see, this is the polycystic kidney, how it looks grossly there, and you can see the size. Normally around 5 centimeter scale, this is around 15 centimeters in size, and you see multiple cysts are there inside that. This is a polycystic kidney. Now you see, this is the contracted kidneys, chronic, granular, contracted kidney or scarred kidney cut section you can see, chronic renal failure, CKD, chronic contracted granular kidney. Now you see end-stage renal disease, polycystic kidney disease with end-stage renal disease, chronic contracted kidney, you can see here in this picture. Now, all of you have the power to prevent CKD. Remember, unless you use the power, CKD cannot be prevented. And I urge all of you to work very hard in identifying CKD very early, and early identification of proteinuria, and renal risk calculation, EGFR, cystatin, and early treatment with ACE inhibitors. Potassium you have to take care, phosphate excess you have to avoid, bone you have to look after, and also look for the anemia. All these together only not only will prevent the chronic renal disease, they will also prevent the CVD, because majority of the deaths of CKD are due to CVD, and we will be doing a world of good. If you take care of diabetes, if you take care of hypertension, 80% of the problem is taken care of. This particular presentation has been drawn from www.kidney.org, that is National Kidney Foundation, USA, NKDP, National Kidney Diseases Education Program, USA, KDOQI Guidelines, Kidney Diseases Outcome Quality Trials, and then Kidney Health Australia, EGFR calculators, Kidney Resources, and then Medical for calculators. That is the website for medicalc.com. Go and download the calculator, and edren.org, that is about the diet. That is education about diet and kidney, edren.org. That's about the diet and kidney. Use these resources, which are links for your CKD furthering your knowledge. And this presentation and this video also will be shared with you. Use this presentation. Take home messages. CKD is a silent killer. We need to uncover it. It will not come like CKD. It will come like asthenia, weakness, and then my mild microalbuminuria, or it may present as CVD. You have to uncover it. Every patient, you take blood pressure and see if look for sugar, and then wait. And then CKD progression is preventable, stage it and treat it. Diabetes is the most common cause of end-stage renal disease all over the globe. CKD more likely CV death than progress to CSRD. That is end-stage renal disease. Multi-risk factor intervention is critical. HbA1c is the goal. ABC I have told you. AA1C, blood pressure, S inhibitors, AA1C, B blood pressure, and then the C is for the cholesterol, D for the diet, and also the diuretic. Lowering blood pressure with ROS inhibitors, combination of SERB plus MRA combinations prevent cardiovascular morbidity and mortality. Newer treatments, SGLT2 inhibitors, GLP-1 receptor antagonists, and NSMRNA antagonists. These are the drugs which you can use. All phosphate binders also you must remember. And dialysis, peritoneal dialysis, hemodialysis, renal replacement therapy is the ultimate thing for those very few unfortunate fellows who go into stage 4 and stage 5. We as physicians are here to take an oath that I will not allow my patient to go into stage 4 or stage 5 renal disease and handle him in stage 1 and stage 2 itself.